I have breast cancer.
I have breast cancer.
I have breast cancer.
And I needed someone to talk to.
I needed information.
I needed to know I could do this. I found Living Beyond Breast Cancer, an organization that understands what you need and need to know. They helped me, and they can help you too.
I have breast cancer.
And I have support.
I have information.
And I have hope. I have Living Beyond Breast Cancer. Find 5 ways we can help you at 5ways.lbbc.org.
Good evening, everybody, and welcome to Living Beyond Breast Cancer's 360. Our topic this evening is entitled Lost in Translation, Effectively Communicating with Your Healthcare Providers. I don't think there's anyone that this topic doesn't have resonance for. We all, at some point in our lives, have to interact with our healthcare providers, and whether we have a serious illness or we're taking care of parents or children. So we're really going to address this issue and help people have the tools to manage this important relationship better. I'm Jean Sachs. I'm the CEO of Living Beyond Breast Cancer. I want to thank our sponsors this evening that make programs like this possible: Genentech, Pfizer, the Avon Breast Cancer Crusade, and AstraZeneca. I also want to give a shout out to a few of our leadership volunteers who are around the country holding watch parties. So Chris Stark is in Montague, Michigan, and Martha Carlson is in Brookfield, Illinois. So it's great. I hope you guys are clapping. It's great to know you're there. But we do know that there are hundreds of you watching this program from around the country. So before we get started, I just want to do a quick message about what Living Beyond Breast Cancer is. We are a national nonprofit, and our mission is to connect people impacted by breast cancer with trusted information and a community of support. And this program this evening is just one way that we put our mission into action, by hearing stories from women who have experienced it. So you'll hear from 3 women who have generously offered to tell their stories very openly, and as well as give you access to a nationally recognized medical oncologist. So we really do hope you enjoy this program. We're going to try to break it up into 20-minute segments. And during the first 20 minutes, we are going to talk to our speaker, Dr. Lidia Shapira. She is a medical oncologist and director of cancer survivorship at Stanford Comprehensive Cancer Institute. And she has really become an expert in the doctor-patient relationship. So we're very lucky that she came to see us all the way from California, although Philadelphia is very warm this evening, so it was welcoming for you. And then we'll hear from Fran and Liz and Rachel, who probably, like all of you, have had really good communication with doctors, and then sometimes not so great, and sometimes really, really challenging. So we'll work on getting into that. Remember, you can text your questions at any time, and that number is 610-624-5671. Janine, my colleague, will be monitoring that, and as questions come up, we will get to them as we can. So please, we want to hear from all of you. So with that, I really want to start with Dr. Shapira. And I was thinking about this. I know for me, when I prepare to go to the doctor, I might be anticipating this appointment for weeks. I might be thinking about what I'm going to be wearing and what it's going to be like. And, I'm going to get all my questions answered. So I come with all these preconceived expectations. And then I get there, and maybe I wait an hour, or maybe I wait 2 hours, and it's very different. So let's start by saying, what is realistic? How can patients kind of have realistic expectations, and how can it be different?
Such a great question. I think it happens to all of us. And one of the things I would say is it's important to know what you need to get out of it, or what you want to get out of it, and to prepare as much as you possibly can. I think it would be great if patients really understood how much time is allotted for the visit first. Mm-hmm. To expect, for instance, that there may be some delays. It'd be great to know where your doctor is at that moment, and if you're going to be waiting 60 or 90 minutes, to be given a warning or even a beeper and told that you can go outside, and they'll call you when it's your turn.
Right, like the restaurant.
As they do in the restaurants, right? So I think all of that, sort of this idea that if they could help you, I mean, what we could do on our end as clinicians, as physicians, is to make it, as easy as we can. Even have a navigator call you before, somebody to help you understand where to park, what to expect, how many doctors are going to be asking you the same questions, how long you may expect to wait, what to do. So I think having respect for the process is important, and from the point of view of the patient, and I put myself in that imaginary spot all the time, it's, just maybe having somebody that you can ask, what to expect before would be helpful.
And do you think that happens more often or less often? Or?
I must say that I think that we're moving in that direction. I think that as a result of a lot of your work and as a result also of the fact that we really are trying to meet people's needs and be more responsive, I think we are listening. We're trying to improve. We're trying to be more transparent in our practices. I mean, I speak for many centers that I know really mean it. So I think that there are signs of progress. That's not to say that we're not still keeping people waiting far too long, and sometimes we're a little abrupt because we're busy or stressed. But I think overall, just this idea that there may need to be a navigator, a nurse, somebody in the team who can help you prepare and get the most out of that visit, I think is a step in the right direction.
And so then once you get in and you're having that meeting with your doctor, how do you define successful communication between the doctor and the patient?
I love that question. For me, success in communication is a feeling of having a solid partnership. To walk out feeling that something was accomplished, that I understood what somebody needed, that I was able to help her. Usually it's women with breast cancer, so let me use that. That I was able to really elicit her concerns, to meet her needs, her information, provide some level of support or guidance, or at least pave the way for a constructive dialogue over time. Sometimes things don't get accomplished in the moment. We all have bad days. We all can be stressed. But I really think that thinking about the clinician-patient relationship as a partnership is probably the best way to go. So people who think about what makes a good partnership, having the same goals, having the possibility of stating who's going to do what, holding each other accountable, building trust. So all of these, I think, are the elements to me of a good partnership and should also work for managing a serious illness like cancer.
So do you feel like things have become better, or are there more challenges, more barriers? We know you don't have as much time with your patients. Insurance companies are controlling some of that, reimbursement issues. So talk a little bit about that.
So the answer is yes and no. And talking a little is hard. I tend to talk a lot, but I'll try. So some of the things that are better is that we're learning to communicate, I think, more clearly, more effectively, and we're building teams. So perhaps the oncologist delegates some of these tasks to somebody else on the team, and members of the team have defined roles. They may not always explain it properly to the patient, and that may be a problem. But I think the idea of the progress and the challenge and the opportunity lies on the part of the clinicians to build good teams, to try to be responsive to what the needs are of each person, and to do that not by guessing but by asking what people need. So people may have different needs for scientific information or for supportive services or to connect to other buddies or to have a way of understanding the complexities of cancer treatment. So understanding what every person needs, meeting them where they're at, having different members of the team with specific roles that patients understand, I think are all the steps that would take us to sort of a better model for providing good care.
So when you're in medical school, how much training are you getting on communication?
Right. So in my days, none, except by observation and by modeling, which I don't want to discount because I think that in many ways medicine also requires an apprenticeship. So if you're lucky enough to have great role models and people who are willing to talk to you and help you as you become young professional, I think that helps. But formally, that was not a topic. Now it's part of the curriculum. In other words, you can't graduate from medical school without demonstrating that you're competent. In fact, some medical schools now are including communication skills as part of their interviewing process for future candidates. So they actually present them with scenarios, and they have, these many kids coming out of college just basically needing to impersonate the doctor and sort of show how they would respond. Right. But so what it shows is that we acknowledge that that's an important part of the professional development. And we want to make it very clear from the very first day and week of medical school that we need to teach these skills. They need to hone these skills. We're going to evaluate them on these skills. So in medical school, they learn to interview. They will learn how to have a respectful relationship and approach somebody as a professional. And then as they go through their training, they're taught, for instance, to give bad news to patients in a certain way. They're shown how to elicit somebody's concerns, how to discuss maybe sensitive topics, and how to express support.
So that's great. So that's a real difference.
Yeah, and then they forget about it as they enter the busy days of training, and sometimes they actually have role models that that are not so good. Right. So in fact, if you study this, you see that people become de-skilled. You teach these skills, and the students show you they're proficient, and the young doctors really take this to heart. And then with time, sometimes, with time pressures and many other things weighing on them, sometimes they become de-skilled. And in part, we've lamented the fact that perhaps these interpersonal skills aren't valued enough to reward people. People are rewarded often on their productivity. And so even those who mean well may have few opportunities to practice or get better. Right. And that's what we also need to fix.
Right. And so what do you think about how high should our expectations be? I mean, doctors are people. You have good days, you have bad days. You don't know when you're walking in what happened to them 10 minutes ago. They might be tired, they might have stress at home. But it's hard for us not to think that we are going to be the most important person that they're focusing on. And is that a realistic expectation?
It should be. And I think you're absolutely right. And I would say that I think of this as professionalism. Professionalism is the ability to be really at the top of your game, even if you're having a bad day. So even if your kid had a 101 fever and you had a fight with your husband on the way out the door, or the dog threw up, whatever happened to you, or whether or not you are stressed because you may have a scientific presentation or a paper to finish, that should never get in the way of giving the person who's in front of you, who's trusting you, the best that you've got. And that's what I mean by professionalism. So there are efforts to help doctors to hone their communication skills, to deal with stress. Often what this means, Jean, is really also to be more self-aware, to realize that we all carry our own emotional loads, but there's got to be some way to handle that so that it doesn't impact on what you're giving as a professional to somebody who's there seeking your counsel, seeking your advice, and who really needs you.
Right. So we should have high expectations.
You should absolutely aim high.
But we should know that not every one appointment might be, better than another, and to have some leeway there too. But also for the patient, I feel like we also have higher expectations on the patients, that they need to come with their questions. They might come with, information. They have to remember everything. So, where's that balance?
So years ago, I had a patient who was living with metastatic breast cancer, who was herself a scientist, and we were both very young then. And she said to me that the reason she stayed with me was because I was educable. Meaning that she could still teach me how to meet her needs because I was listening. Right. So I think from the point of view of the clinicians, what you want is to have somebody that you feel you can work with. And you may not hit it all right every time, or it may not look great at the beginning. But if you feel that person is both competent and warm and educable, maybe you should invest in training them.
Right. And maybe that's where the team approach really helps. Because I know for many women with breast cancer, it's often their oncology nurse or other people on the team that they're seeing more often and communicating more regularly with.
If you have a good team and if your needs are met, I think that's fine. And certainly it's not all about the clinician necessarily or the oncologist.
Okay, so we have to understand that. So can you tell us, I know we hear this buzzword a lot, what is shared decision making? And I know, doctors are being asked to talk about a lot of things with patient, including costs sometimes, that's starting, the cost of care. So what is shared decision making and how do we achieve that?
So those are two different questions, and the issue of cost is, weighing heavily on all of our minds. But shared decision making basically means bringing the patient into the conversation when you're going to choose a treatment. So if two treatments have similar outcomes, whether it's having breast conservation or mastectomy, the survival outcome may be the same, whether it's to choose to have one type of chemotherapy or another, or no chemotherapy and hormonal therapy. Those are situations where perhaps there's several different ways to go in order to achieve good outcomes. And the right decision is what's right for that person, because scientifically you may say that they're equal. So shared decision making means that the oncologist or the clinician needs to ask the patient how much they need to know, how much they want to participate in making that decision, and then giving them sufficient information and sort of having a deliberative process where they're thinking about all the different options and then arriving at a decision together. It takes time.
Right.
It takes preparation, it takes information, it may take more than one session, but that's what we typically mean by shared decision making.
And that's hard, right?
It is hard.
Because I think often, when you're diagnosed with a serious illness like breast cancer, I don't think patients know before they're diagnosed that they may have to make some decisions, that they're not just going to be told, this is your treatment plan, this is the gold standard. And we talk to a lot of women at Living Beyond Breast Cancer who, this is a very stressful time period where,
Absolutely.
You're trying to, so you really need to trust that you need someone leading your team, right? You need to figure out who's sort of the captain of the ship, so to speak.
But it may require somebody just being able to say, look, think about this. You think you have a decision, and then you say, well, let me complicate your thinking. Now, we have a clinical trial.
Yes.
That is actually testing something that's novel. Can we have that conversation? And if you start to think about this, it can really get quite complex, and it may be very difficult to arrive at the right decision in just one session with somebody who may be very well prepared, but may be a complete stranger to you, at that moment. So it's a process, really, and it takes a lot of skill and time.
And do you feel that breast cancer patients have more of that decisions than other?
I absolutely do.
Yeah.
And we hear about this all the time. There are more decisions that need to be made. And also the breast cancer community is one that, is used to sharing and thinking about this, and where we have actually taught women to seek a second opinion if they're not satisfied. So there's a whole lot of this also that I think contributes to the fact that women want to be very engaged in their own treatment, and of course that starts with making the right decision.
Right. So with this shared decision making, do you feel, obviously if you were my doctor, I would feel really comfortable sort of maybe going back and forth with you, but do you feel like most medical oncologists are able to do that and not show their bias, or not sort of throw in, well, if you were my wife, this is what I would do?
I know this happens all the time, and some biases we may be aware of, and some we may not. The whole concept behind this idea that we may have unconscious biases is that we are not aware of them. So yes, you're absolutely right. If I could say to somebody, look, if you were my mother, right, I would tell you to do this. If you were my best friend, I would tell you to do that. But at the end of the day, I think what we need to do is to teach the clinicians to be able to present various options, and to respect any decision that's reasonable, even if it is not exactly the one that they would make.
Right. My father is a psychoanalyst, and he used to always say to me, you don't know, they might hate their wife or they might not like their mother. So that doesn't necessarily mean they're giving you the best plan. So I think it is important to know that.
I've had patients who've asked me, what would you do? And of course, since I'm, we're peers and it could be me any day sitting there, I usually take that to mean, do you care enough about me to really give me an honest opinion? And so I answer sincerely, but that doesn't necessarily mean that it's the right decision for them.
So I think what we're saying is it is true. Women diagnosed with breast cancer are facing lots of choices. Women living with metastatic breast cancer are in ongoing treatment and they're facing ongoing choices. And so this relationship with the doctor is so important, and you should have those expectations. So I know we have a little slide on how to prepare for I think you worked on this, on how to best prepare for and I love this, it's called PrEP. But maybe you could talk through this and sort of help people have a tool.
So if a friend is diagnosed and I have a chance to chat with her, the first thing I'll say is take a moment and be compassionate with yourself and just realize that, you need to help yourself to get through this. Try not to do this alone. In order to prepare for a consultation, try to have a list of questions, rank them by importance, so you're sure that you ask the things that mean the most to you at the beginning and they have a chance to be answered. Reach out to someone to go with you. Try not to do this alone, and have somebody hopefully who can go and take notes, and then debrief with you. Evaluate your goals. Try to be clear on what it is that you need to do. What is most important to you in terms of time, in terms of physical expenditure of time, or what you're hoping to achieve through this consultation and obviously through the treatment. And then to have a picture of what a positive communication can look like. What is a good partnership? What is a good collaborative relationship look like to you? There may be some for whom it's really important to have that warm dimension, and for others who may turn to cool as long as information is exchanged.
Yes.
So it's just sort of a matter of trying to understand what's really important, but going in there with some information, with a plan, with a strategy, with a companion, and with a clear mind.
Yeah, I know some people bring the whole family, and
it's hard for us sometimes.
Yeah.
We don't know where to look.
I know. All right, well, we've covered a lot in the first 20 minutes. I think I've gone a little over. So we're going to, and our women have been so patiently waiting to share their story. So we're going to move over, and we're going to start with Fran. And Fran was diagnosed with stage 3 triple-negative breast cancer about 12 years ago. So congratulations. It's a good amount of time.
Yes.
But I know you have a story about when you first met with your doctor and you had a treatment plan in place that you felt comfortable with, and you had expectations, and you knew that your expectation was that in 3 weeks you were going to get surgery and then chemotherapy and radiation. But I don't think that's what happened. So.
Oh, no. No. I went to the pre-admission tests, and as they always do, they ask you a gazillion questions that you've answered 12 times before. And at the end of this, the admissions clerk says, and you know what procedure you're going to have. And I had prepared myself. It's okay, I'm going to have a partial mastectomy. I'm ready for this. And I prepared my whole support network. And so I said, of course, I'm going to have a partial mastectomy. And she said, no, you're not. Yeah, that's what it is. No, that's been changed. You're not going to have that happen. I was not, real pleasant about that. But I said, well, let me see on the paper, because that must not be my paper. And she said, no, you're going to have a port implanted. A port? We had not discussed a port. Well, that's where so you can get your chemotherapy. Okay, so now it's time, trying not to show my disappointment to the admissions person who, just got the papers. I decided it was time to talk to my doctors, because I had just seen them the week before. I met with each of the 3 major doctors that were working with me, and nobody said that anything about a port, because I was supposed to have the surgery and then the chemotherapy, and then the radiation. So I called them. And I called them. I didn't want to talk to the nurse. I didn't want to talk to the receptionist. I wanted to talk to my doctor. And I got through, actually, to each of them. And fortunately, they each said the same thing. Well, after we looked at your total treatment plan, and we looked at all the last lab results, we knew we had to move quickly because the cancer was growing so rapidly. We couldn't do the surgery, so we're changing your treatment plan. And since you were coming to the hospital anyway, we just decided to do the chemo first and do the surgery later. And not being real thrilled about them making that decision because they had talked to each other, but they didn't talk to me. And I don't want to say furious, but I was. And after actually probably maybe just a little screaming at them to never make that kind of a decision without me, they all apologized and said, well, we just knew that this had to happen quickly. And, the issue is it was never about the clinical decision. Obviously, that was the right decision to make. It's just that they made it without me.
Right. So, Dr. Shapira, what happened? I mean, this does seem very. I would hope is very unusual. Maybe it's not, but I mean, I know what it's like to have to prepare for surgery and have an expectation. And I'm sure you had people.
Oh, my whole family.
Yeah, they were all there.
I was one of those families.
So this is a black and white situation of communication gone wrong. I mean, somebody just forgot to tell the patient that the plan changed. This is just like awful. So I'm completely with you there. I think I would have been furious. And I think the right response is exactly that, to say, wait a minute, you forgot me. And I can imagine how it happened, that, everybody said, oh, I'll call her, nobody called her. But they owed you that phone call, and they owed you that apology. I mean, this shouldn't happen.
Right, and good for you for yelling and being furious.
Yes.
Because
just a little.
Right, well, I'm sure just a little for you might be.
Yeah.
And I'm sure that maybe will help the next patient.
I hope so.
Yes.
I hope so, and I hope
helped
those
me.
doctors are still mortified to this day that they forgot to call you and that it's helped them somehow to change the protocols.
Right.
Fortunately, nobody got hurt. Over the long haul, but that
That's
day
because
must
it
have
was
been
a phone
awful.
call.
Yeah.
All right, so Liz, we're going to move on to you. And I know that you were diagnosed with stage 2 triple negative breast cancer about 3 years ago. So good 3 years is a good number too.
Closer to 4, actually.
And I know you're also in the healthcare industry. You've been a physical therapist for more than 20 years. So this wasn't an unfamiliar world to you that you were walking into. But when you knew you were going to have radiation, you had some very specific concerns because it was on the left side, which you knew put you at greater risk for heart damage. And you wanted to make sure you had the best radiation oncologist. So tell us what happened with the doctor you ended up working with.
Okay. I had asked to be seen by the absolute best in the organization. The research that I had done, I felt that radiation treatment was a little bit different than oncology because to me it seemed more skilled. And I was concerned, because it was going to be happening over my heart. So extremely, extremely intelligent physician, but his bedside manner, I think because he was so intelligent, was lacking at times. He seemed...
Take exception to that. We shouldn't allow anybody to have a pass.
Yeah. He seemed, clinically he was amazing, but the social cues lacked at times. He had a tendency to, when he was explaining things, he was very passionate. He'd kind of get right in my face. And, you're so full of emotion to begin with that, I would feel my blood pressure rising. And I was already on board, with treatment. So he didn't really need to convince me as much. I felt like he was kind of following a script for women who needed to be convinced to get radiation, and that wasn't me. So, and I just, a couple times just had to say, you need to stop, back off. I'm getting tunnel vision here. And he did. He listened at that point. And I stayed with him because he did try to then step away and come back with a different approach.
And did you have a specific conversation that was a struggle, or was it just his mannerism that was challenging?
Both. I mean,
Okay.
there were a couple different conversations that were a struggle. I think the worst was when I was coming to the end of my treatment, and that can be highly emotionally charged because you've been with these healthcare professionals for 6-7 months, sometimes daily, and they say, "Oh, you're finished. We'll see you for your annual mammogram." And I wanted a plan. I had a lot of questions. What if questions? What if it comes back in the other breast? And this physician said, well, it's not going to come back in the other breast. And again, he's in my face. It's going to go to your liver. It's going to go to your brain. It's going to go to, and they actually had to call in a social worker to talk to me just because I was really having a panic attack. So he left, the social worker came in, she understood immediately what I was talking about and apologized for him, went and spoke with him. He came back in and apologized profusely, So I always felt like he was trying to get better at communicating, so I never gave up on him. He was educable.
I think there's a couple things with both of these stories. I mean, both of these women had hard situations, but they stayed with their doctors and said, we still think they're excellent and we trust them. So my one question is, at what point how do you make the decision to leave or to get a second opinion? And then I think Liz's point of when a doctor gives you maybe a little bit more information that you want, what do you do about that?
I mean, these are the tough questions. It's hard to know when to say to somebody it's enough. Mm-hmm. And ideally, we want this is not just my thinking, but research has shown that we want oncologists, or patients want oncologists to be both warm and competent. And at some point, if you don't feel that I think in Liz's case, she felt the competence was so great that she was prepared to excuse a few problems in interpersonal skills, but boy, do I wish I could have him in a course for communication skills training, because that's what we do basically. We try to help people to think about how to be better at the communication piece. You can have all the technical knowledge in the world, but if you don't know how to keep your distance with a patient, if you don't know, just saying that he's in your face does not speak well of even how he comes into a room. Not asking you, what exactly you were asking about, and not picking up on this cue that you were having this very normal anxiety about the end of treatment, when most of the time we know, and there's literature to support the fact that many women feel that their safety net is about to go under, and they're anticipating being scared or not knowing what's going to happen and when, and they need a clear roadmap, and they need support right at that point. And the support can be delivered in different ways, but that's what they need. So I think in both of these situations, what we're looking at is a failure of communication. That's my diagnosis. If there were a code, that's what I would say. That maybe the competence was there, the right treatment was delivered. Nobody was hurt, but the communication was not good. Right. It was more than suboptimal. It was actually harmful. In one case, it led to somebody feeling bewildered and furious and, sort of not properly cared for. And in the other, it led somebody doesn't seem to me like somebody who would normally have a panic attack in the doctor's office to actually fall apart, because the information that was delivered was blunt, not information she asked for, it wasn't ready for, and it wasn't accompanied by support or a proper exchange. So I think these are both examples of competent professionals communicating poorly.
Right. So we'll get back to when does it make sense to switch, because I want to make sure we bring Rachel into the conversation. Rachel, I know you were diagnosed about 2.5 years ago with HER2 positive, ER positive metastatic breast cancer from the start, so you never had the early diagnosis. And I know for all women who face that, you get a lot of information at once, and it's very overwhelming. But I want you to just start to tell us about that first conversation you had with your husband when you were on your way to the oncologist's office.
Sure. So I received, the first indication that I was about to get a metastatic breast cancer diagnosis out of the gate, my spine was broken in 3 places, and it had been for about 4 months. And I had been going to primary care repeatedly, to physical therapy, really trying to get to the bottom of this back pain. And then I had an MRI that showed 3 spinal compression fractures. And it was actually the orthopedic surgeon who identified, I've only ever seen this in a woman your age, I was 38, with a metastatic cancer. And so in that time, I had my spine operated on. I had all of the scans done that showed that the cancer was actually in every bone. And so then I had my first appointment with a medical oncologist. So I was, my husband and I were driving in sort of from the context of we didn't even know one could be diagnosed metastatic out of the gate. I had thought the worst thing would be either I had to have back surgery or I'd have to wear a back brace, and oh my gosh, that was so embarrassing. Or you could have this metastatic cancer diagnosis. And so, driving in, we didn't know what to expect. I mean, we were terrified, and we have been together since summer camp, and and it's not a long ride from my house to the hospital, but in that ride, I mean, we said all of the things you say to your loved one when you think you don't have a lot of time to say those things. I mean, my kids were 8 and 10, and I was giving him instructions. I mean, it was a really, really scary, horrible time. And, and up before that point, I had been living a really normal, successful, happy, healthy life. And so, so going to the first appointment with my medical oncologist, we were about 2/3 of the way, into the appointment when, she had shared so much information about what HER2 positive breast cancer meant, what the treatment options were, how receptors worked, what all of the hormonal options were, what this would look like going forward, and how frequently treatment would be. And we got really, detailed quickly, and she shared a lot of really important information. But, my husband and I sort of stopped and said, like, but what is actually happening? What does this really mean? And she said, you're going to go back to work if you want to go back to work, and you're going to go on vacations with your family, and, you're going to have a fairly typical life. You're just going to be coming to see me a lot and going on, medications, and we'll try a medication, and when that stops working, there are other medications, and, we hope that other medications are being developed, and we just keep stringing them along. And I think thinking of how we went into that appointment and the real doom and gloom that we entered with, we walked out of that appointment just feeling so much lighter and so much of even feeling like we could dare to talk about a future.
So I'm just going to interrupt you because thank you so much, but I want you to be able to respond that here's an example of what I think is really good communication, probably a lot of information, but presented in a way that really turned around your concerns. So,
Did it feel comforting to you?
Yes, and I think my oncologist's manner is incredibly comforting. I have a fundraising background, and for me, building a close relationship really quickly is how I feel comfortable. So that was really important, and it was as important to me that we were able to talk about my kids and her kids and parenting in it was as important to be able to talk about those things and feel like we had a rapport as it was to talk about all of the clinical things. And absolutely, I mean, we, very early in the relationship had the conversation of, I am putting my life in your hands, and is that okay? Are you okay with that? And I said, am I supposed to be the one researching treatment options, or are you doing that? And she said, no, like, I've got this. You go out and live your life. And I think the extreme level of trust that you need to have in order to be able to do that, I think really speaks to the way we're able to communicate with each other.
So this is a beautiful example, I think, of warmth and competence and the ability to form a connection. I think that, from everything I know about communication, from my own experience and the way I teach it, is that it is important to have this human to human. In your case, it may have been mother to mother. It may have been to find something that really creates these bonds. And then to have somebody who says to you, I've got your back, go lead your life. And we're just going to have to figure out a way of working together. But think about life. This is about your life, not just about your cancer. This is a place, our visits can be a place for you to deposit all your fears, your worries, your concerns. But then when you're out of here, go lead your life. And I'll do my best to keep this going as long and as well as possible. So this is a lovely example, I think, of positive communication, good communication and connection. And just think about it for 1 second, not that it's your job to do so, but think about what that also means to the human being who's sitting in that chair. I mean, she's got you, she's got your worries now. And so I think part of our training, again, to help the professionals do this well, is to figure out what to do with all of that emotional load, so that it's done properly and people still feel fresh and ready to say, sure, I'll take this on.
Right. I had the same feeling, which is that is some really good insight as to what it's like for a doctor who's not just got your back, but presumably hundreds of other patients.
But
So
it's important to form those connections. Gina, one of the interesting things is that I remember, I had a very large practice, and now I'm doing a little bit less, but for a while, and I wouldn't take notes, but from year to year, I remembered the names of each woman's kids and the grades they were in. Yeah. And it's just because I was completely present in that moment. I didn't need to to write it down. But these are the things that I remembered more than perhaps the biology of the cancer.
Right.
And I think you need a little bit of that.
And that's always appreciated, I think, because you're walking in, it's already a power dynamic, but if your doctor can immediately say, how's your daughter doing? Not, is she in 5th grade now? I know we're going to have to move on, but I know you had another conversation with your oncologist recently where your doctor told you were doing great, but that didn't really sound so great to you.
Yeah, and I think, yes. So I had an appointment recently. So now I've been in treatment for 2.5 years. For the most part, I have been living a fairly typical life. I do all the normal mom stuff. But I was leaving the appointment, and she said to me, we were, sort of stepping out of the office into the hallway, and she said, it makes me so happy to see you because you're doing so well, and everything that we want to happen is happening. You're just doing so great. And at face value, that sounds wonderful. I mean, I have a metastatic diagnosis. My oncologist is telling me everything that we want to have happen is happening. Isn't that great? I got in the car and sobbed the whole way home and really had to think, like, what did that trigger? And for me, I've had 2.5 years of grueling treatment, of not feeling well, of losing my career, of feeling sick pretty much every day. And I think for her looking at me, she's comparing me to, this sort of broken, newly diagnosed person that I presented as 2.5 years ago. I'm sure she's thinking of patients that she has lost in her career who had similar diagnoses to me. I'm sure she's thinking of me in the context of patients that, she had before and after me who aren't doing as well. And from that perspective, yeah, I can see why I make her really happy. But I am still mourning who I was before this cancer diagnosis. And
okay, so Rachel, I'm going to stop you because you've got so much to say and it's really rich. But I know we want to move on to some, and I know Janine has a question, but this is a really interesting issue to me. I mean, here a doctor is saying you're doing well, and yet that's not feeling so great.
So what's the diagnosis?
Yeah, what's the diagnosis?
So it's great that you're doing great, but it seems to have been more of a generic comment, right? For this, given what we can expect or whatever things are going as we schedule, that's fine. But it was not tuned into where you were. So whether or not, I don't know what happened, but whether or not you didn't cue her to what you were really thinking about, or whether she missed the cue, or whether both of you were, performing for each other, going through the motions of what these regular visits are like, and all the columns are checked, and so she basically gave you a generic, statement of encouragement, which was basically meant to say, like, great work, right? But it didn't feel right to you. It's sort of hard to know. My educated guess is that at this point you are, as you say, dealing with grief and mourning all of the things that you've lost as a result. You may have more symptoms every day than you and she actually speak about. So there's a lot that the illness has done that still needs to be addressed and processed. And perhaps at this point, what you may think of doing is maybe even engaging somebody else, a psychologist or a social worker, or bringing these issues to some other forum. Whether or not you want to do this with your oncologist or not, it will be, you seem to be so incredibly thoughtful and prepared, is really your choice. Whether you want to call her on it and say, I really need to have a different conversation with you, or can you refer me to somebody who can help me address the fact that, I'm just physically not feeling well and emotionally struggling a bit.
But, good for you to taking the time to figure out why did that not feel good, because sometimes we don't even do that. Janine, do you have a question?
We do. We have several questions. So I'm going to start with this first one from, I actually have a few that are sort of similar, where people are saying they're very grateful to be able to hear from Dr. Shapira, but feel like you're an anomaly, that there are physicians out there
I've
that,
heard that before.
that really just don't have compassion, don't listen. And I think that really speaks to the question of what are the red flags for when you really just don't have a good match with a physician and should move on, and how do you do that?
The red flags are feeling that you're not seen as a person, feeling that somebody's, talking to you from a script, or that they just are not interested, or they don't have a good team. Again, you may be able to excuse that if there's a team surrounding that oncologist who actually does pitch in. So if you have a very busy oncologist who's a great researcher maybe, but has very little time with patients, but he or she has a wonderful physician's assistant or a nurse practitioner or a wonderful oncology nurse, you may be getting what you need. So I think the red flags are feeling unknown or dismissed or not seen or not having anybody in the team who really can have what we've all here talked about, which is that personal connection. So we need both technical expertise, but we also need a connection to get through a serious illness.
I think I want to circle back to a question we sort of started to touch on when you were telling your story about, or when Liz was telling her story about fear of recurrence. That's a really key conversation that people with early stage breast cancer have with their doctors around what are the risks of this cancer coming back. And I'm wondering if you could talk a little bit about a way that conversation could have looked different so that Liz could have gotten the information that she needed so it was accurate and she understood the risks and would have a sense of the next steps.
The fear of recurrence is emerging, in the scientific literature as the top concern among cancer survivors, and especially among breast cancer survivors. And there's actually some interesting research as to how we can intervene to make these things better. So it's something very real. It should not be confused with an anxiety disorder or depression. It's just something real that happens to people who may be very competent in all areas of their lives, but are coming to this juncture point, and they really don't really know how to address that. And it has to do a lot, I think, with one's ideas about uncertainty and how we manage uncertainty and not really having control. So it's a combination of a lot of different emotions that may look a little bit like anxiety, but also have to do with just needing that, a bit of structure, maybe reassurance, maybe just knowing that one is doing this with the proper support. How ready people are to have the conversation of what the prognosis is something that a good clinician needs to assess before coming in with perhaps what sounds like too much information or blunt information. So at the end of treatment, perhaps it's important to go over what happened, and that's part of what people in survivorship care are thinking about, that there needs to be some transition visit or process to help people understand what went before and what comes after. And our goal as clinicians ought to be to help people feel confident about the future. And it may take different kinds of maneuvers, sometimes a lot of interventions or a lot of information or a support group or something, or frequent visits to try to address all of those things, both to give people the knowledge that they need to know what to look out for, also to have a structure of what the follow-ups are going to look like, and then also to normalize the fact that this really does happen, and time often heals.
Mm-hmm. So we moved into thorny situations with Matt without me even saying it, so that's great. But I know before, when we were just all chatting, Rachel brought up social media and this phenomena that's been growing and growing, and I'm sure will continue to grow, which is that there's so many communities out there where you leave your doctor's appointment and you share with maybe thousands of other breast cancer patients from around the world. I mean, they could be getting totally different care. I just had this, and then they get a lot of information and they come to their doctor and they have a lot of questions. And what is that like for the doctor? Is this improving our communication? Is this making it more challenging?
It's making it more challenging for sure.
Yeah.
It may improve, but it also may not. Doctors don't really know how to deal with this yet. The younger doctors, or we don't yet have a generation of digital natives, as I think of them, in medicine, but they're coming. And so in the future, I assume everybody will be very comfortable with it. But in this moment, it may be a bit of a problem. I had a patient not too long ago who is herself a physician in her 50s, when I asked her, what helped you the most when you got through your treatment, she said Facebook. Mm-hmm. I was on several communities, and I looked at her in horror. I said, I would never have guessed. And she said, yes, it was really comforting to realize that women all over the country were receiving the same treatment. I learned a lot about non-pharmacologic treatments for common symptoms, and it was supportive. So I think we need to figure out what role social media is playing, both in terms of providing information, which may be valid or not, and support. In some cases, perhaps social media is not so great in that it may lead somebody to be unnecessarily frightened. But for the most part, it seems to be working.
Right.
And just what the right dose is, what the right mechanism is, how to send people to the right group, perhaps, or to the right site, remains a challenge for our profession, and we have not yet tackled it.
Right, and it certainly is sort of changing the dynamic between the doctor and the patient, because I certainly know I took care of my mother as you took care of yours, and probably many of you did. She listened to her doctor, she wasn't doing research, and we're suddenly coming in and challenging them and maybe know more about a study than they do. So certainly changing times. So I know
one of the things that I think that is important for clinicians, which I've learned, is that there are often a lot of people in the room that you don't see. So there may be all of the family members who are not in the room who are giving advice, but in the case of social media, there may be, as you say, thousands of other people whose input is going to influence whatever decisions are made, and they remain invisible.
Right, and it is, I think it can be incredibly comforting, and I know that for some of you it has been, and it can also be confusing. So I know we're coming towards the end, and I do want to let each of you sort of just say your final words about, how do you envision good communication? So Fran, why don't we start with you?
Well, I really think it's important that communication works both ways, that we, the survivors, are in fact sharing what's going on with us, with our physicians, because if we're not open, if we're not talking, if we're just sitting back and receiving, first of all, we lose out on a lot of things, and things happen that we could probably avoid. But it's important for us to talk to our physicians, and I found that once I started talking, they started talking and told me all kinds of things that I probably would not have heard had I not asked or spoke up about what was going on and what I felt I needed. So being bold about what's going on with you, being bold and informative to your physicians really helps them treat you. So if there was anything I wanted to leave, especially to survivors, is speak up. Speak up.
Thank you.
I agree. On the patient side, for sure, advocate for yourself. Don't be intimidated. And then on the physician side, I would say, not being so stuck on that script for every patient. Listen. Treat them as individuals.
I think in the metastatic setting, I think, having knowledge of what your expectations are going into the visit are really important. I know for me, I'm actually less interested in what I'm learning about that moment in time. I'm more interested in sort of predicting what the next 6 months of my life will look like. And I think being clear in that that's the kind of information that I'm looking for is really important. And I think, knowing that the interaction is really brief, but whatever happens in that interaction really influences how I feel about my own care and my own life going forward. It's really important to have that clear expectation going in.
That's helpful. How about you, Dr. Shapira?
I'd say speak up, speak sooner, and I come back to this idea that compassion really needs to be engaged on both sides, and we need to do what we can to nudge compassion, to create the kind of situation in that consultation room where compassion can flow in every direction.
Great. Well, it's encouraging to know that medical students are being trained on this, and that maybe the next generation will be, more aware. And I think we see it more and more. But I think we learned a lot. Thank you so much. And I really appreciate all of you sharing your stories, because I think in some ways the best way to learn is, that's probably why we all love social media so much. We can hear everybody's stories, but we don't have to be living them as much. But it's really helpful to say, you guys have been all through these things, but you've stuck with your doctors. You still feel like you have good care. And you didn't get to that point where Dr. Shapira was saying, where you feel like you're invisible and you need to move on. So I want to thank all of you. I want to thank our in-person and our live audience, our virtual audience, I should say. I want everyone to remember that Living Beyond Breast Cancer is here every day to provide support, and we do that in lots of different ways. So please go to our website, lbbc.org, and we have guides for understanding. We have a resource sheet that will be really helpful for everyone we'll send it to you, and we have it here. I want to thank our sponsors again, and I really hope you'll continue to tune in to Living Beyond Breast Cancer programs and stay in touch. So thank you.